all those years that I've been in practice. Actually, I have a private practice here in Brazil where I do exclusively orthodontic treatment in adults and young adult patients. I'm an orthodontic specialist when I started. And for those that don't know me, I'm Wislei Oliveira. And so we're going to discuss more about, we're going to focus more about the mechanical aspect of the correction of a deep bite rather than spending time on its etiology. And deep bite or deep overbite, they mean the same thing really. And it can be defined by the overlap of the upper incisors over the lower incisors greater than 2 or 3 millimeters. Apadihe and Nanda they used to classify the deep bite as normal when there is an overlap of the upper incisors over the lower, and when it covers 5 to 25% of the total length ground of the lower incisors, they consider it a normal. When it goes to 25 to 40%, they consider it a moderate deep bite, and greater than that, 50% or more of the total length of the lower incisors crown, they consider it a severe deep bite. And the deep bite must be corrected because if you leave it untreated, it may cause over the time a crowding on the lower incisors. They also may cause a flaring and the diastemas on the upper arch, especially when we have some impingements on the papillas of on the lingual side of upper arch, what can lead to some bone loss, and consequently, we're going to have some flaring of the upper incisors. And some authors also say that it may be a cause of a temporomandibular disorder, especially in those patients that have a class 2 division 2 with a deep overbite. And how we treat it. So the mechanics to be employed will be determined by our treatment goals that establishing according to the characteristics of the malocclusion. And these characteristics will be defined on after our analysis that can be, you can use our WebCeph analysis and also our facial analysis that I like to use it. And I use it very often to establish our treatment goals, okay? But for example, in this young boy, we have here not severe, I would say like a moderate deep bite, but I rather correct this by intrusion of the upper incisors. If you take a look on the patient's, upper lip, you see that he has a very short upper lip, what shows a little bit of the gingiva during the smile, even at rest. So to improve her smile, I'd rather work on with the intrusion of the maxillary incisors. But we also have in a situation like in this young lady, even though she has a quite shiny smile, but we can see that she exposure his anterior teeth, upper teeth quite well, quite nicely. I wouldn't make any change on this. So I rather work with the intrusion of the lower arch. So by now we can see that we have at least 2 different approaches to correct the deep bite. But I could also add here another possibility, that is the intrusion of the maxillary and mandibular incisors. And this gentleman, we can see that we have an over-eruption of the upper incisors, but also we have some collapse of the occlusal plane of the lower arch, probably due to some loss on the posterior region. So I rather corrected this deep bite working on the up and lower arch to correct it. So now we can add one more possibility. So we have at least 3 different possibilities to correct the deep bite. But it's not all. I can also correct the extrusion with extrusion of a posterior teeth. This is another possibility. And I rather do it, I recommended that we do it, especially in the patients that still have some growth, because we know that when you change the vertical dimension of posterior region, you may cause a rotation of the mandible. So if we still have some growth, it can be compensated by some growth on the mandibular ramus. And so in this patient, we can work with extrusion of posterior teeth, but also combine with the intrusion of the lower incisors as well. And this extrusion, I may subdivide it in two possibilities. I can do this extrusion by translate the posterior segment or just rotate the posterior segment. Okay, so we can say we have at least 5 different ways of approach to correct the deep bite. So we may have any specific mechanics to be more efficient in our treatment. And this with that we are going to talk today a little bit about the possibilities that we have. Here I list probably the most well-known methods that we have to correct the deep bite, starting with the step bends. That is the most intuitive and easy way to do it. And so if you want to move one tooth up, all you have to do is just make a bend up and insert it into the bracket. But that there are some side effects over here with this method that I like to point out for those that are familiar with the Burston's geometry. We have what we call a geometry 1 here, but if you are not so familiar, what we have after inserting any step bend on the 2 neighboring teeth, what happened is you're going to have an intrusive force in one tooth, and by the sake of the equilibrium, you're going to have an extrusion on the neighboring teeth or neighboring tooth. Okay. And we know that the extrusion movement is a type of movement that happens much easier than the intrusion. So extrusion just stretch the fibers and you extrude the teeth. For intrusion, it needs to wait for a sequence of events to start in the remodeling process of bone. So it takes longer time. So at the end, what you may see is more extrusion than intrusion. Besides, we have some moments that will change the axial inclination of the teeth. And also, as we are working in a very short distance, interbracket distance, generally 7 millimeters of interbracket distance, even if you use a very thin wire, for example, 014 stainless steel wire, we can see using this bending toolkit that it was designed by Professor Casey Choi from South Korea. It will generate very high forces, something around 350 grams of forces in each incisors, for example. I think it's quite high forces, okay? So another way that we have to correct the deep bite will be the curve of the spit. We call it the reverse curve of the spit and the pronounced curve of the spit on the upper arch. This is probably the most very well known to correct the deep bite. It's being used worldwide. It's very efficient, very nice way to correct it. I just like to call your attention on some side effects, but we can consider this is a great possibility to correct the deep bite. After this, we can also cite the bite plates, especially when we desire some extrusion of the posterior teeth. Here we can also think in those turbo bites that some colleagues like to use it. Even the lingual brackets do the same thing, really. And I also could add here some orthopedic removable appliances like the Bionators of Harvard, the type 2 as described by McNamara, which allows some differential extrusion of posterior teeth. So they allow some extrusion of the lower posterior teeth and hold in place the upper posterior teeth. After this, we can cite it here also the burst and intrusion arc. This is a variance of the utility arcs using on the Ricketts technique. And the difference is that we do not insert the wire into this slot. And you're going to say a few words about this, why we don't do it. And finally, I can add to this list the skeletal anchorage after the mini screws came up to the market. So it helps a lot as to produce some type of movements that was considered very difficult or sometimes even impossible to do. So this is some different ways that we can use. Which one is the best appliances to use to correct the deep bite? Well, I like to say that there is no good appliance or bad appliance. There are appliances that are used at the right way, at the right moment, and there are appliances that are used in a wrong way. For example, you may use a knife to tighten a screw. You may do it. But if you use a screwdriver, you're going to get a much better performance. Okay, just a matter to select the right appliance at the right moment. Let's start it with the reverse curve of speed and see what happened when we inserted a reverse curve of speed on the lower arch. If you take a look on the sagittal view, it looks like a segment of a circle. Of course, there are some variances on this shape. I'm seeing some colleagues doing a reverse curve of speed where the posterior segment is almost flat, is a straight shaft, and the curvature is more pronounced on the interior region. But regardless, the shape that you do, it could be more round, could be like a logarithm shape, or it could be like a segment of a circle. The force that will be delivered by this is quite complex. I really tell you that we have already described in the literature, if we inserted in a smooth curvature in a set of a bracket that is aligned. This has been done by Kojima and Fukui. They using a finite element analysis. They, of course, they could see that the movement will be just moments. So this is going to release some bending moments all over the segment. Okay, giving only rotation of these tooth. But in a set of a teeth that we have different geometries, we have to consider this as well. So at the end, I would tell you that it's quite complex to define really the real force that, but we have a possibility to give you an idea what at the end what we're going to get is. So you're going to get some bending moments distributed all over the arch, and some extrusive force acting especially in the middle section of the arch, and intrusive force acting on the terminal ends, an anterior part and on the posterior part of the arch. So in this way, with some extrusion and intrusion of a different part of the segment, we can leveling the reverse curve, we can flatten the curve of speed that help us to correct the deep bite. Okay, so we all know that this extrusive force on the middle section of the arch, there are some aspect here that I like to point out based on this study that was being published in 2017, where the colleagues used they determined the effect of leveling a curve of speed in a subject treated with pre-adjusted appliances and different skeletal vertical patterns. They used 3 groups, subjects with a normal angle group. They use a low angle group and a high angle group. Okay, and their conclusion was something quite logical. In the low angle subjects, leveling of a curve of speed occurred through buccal movement and intrusion of the mandibular incisors in a low angle. And a high angle subject, it occurs through extrusion and uprighting of a posterior teeth. So just let's go back a little bit on this diagram here, based on that study. So in a low angle patient, we know that the low angle patient, they have a more strong muscles, more powerful bite. So their occlusion is strong enough to cancel or at least to reduce this tendency of extrusion here on this middle section, okay? So all the deactivation of the wire will be more on the anterior and posterior region. And anterior is okay, that's what we wanted to correct the deep bite. But on the posterior, we know if you intrude the posterior teeth, it helps to reduce, we're going to increase the deep bite. So it seems that you are going nowhere. And this is what happened when we are correcting the deep bite in a very low angle patient. It seems that it doesn't work. So normally what we do, has a natural tendency to increase this curvature, thinking that this is going to help us to open up the bite. But doing this, we're going to increase the intrusive force here, and the case it doesn't. We don't succeed very much. So I recommended you under these circumstances, you may want to add a vertical elasticus on the posterior region. In this way, you cancel this tendency of intrusion here and transfer this intrusive force more to the anterior region. So if you're working on the low angle patient, and want to use the reverse curve of the spit, consider the hypothesis to add some vertical elasticus on the posterior region to help you. If you are in the high angle, so be careful unless you have an extra source of anchorage. So if you put just the reverse curve of the spit, you're going to see a lot of extrusion because the high angle patient doesn't have this powerful of occlusion to cancel this extrusive component here. So the tendency is to open up, to cause in a rotation, open up the bite, but causing in a rotation of the mandible clockwise, what can even become, in your case, even worse, become even more vertical. So another drawback of the reverse curve of the spit that we should have in mind is when we use, normally we start leveling and aligning this curve of the spit in a round wire. And if the reverse curve of the spit is bending in a round wire, 1 degree of freedom is lost. What does it mean? So you don't have the third order control. So the intrusive force acting in the anterior region will be similar to the one produced by a free end of a cantilever. So you have just one force acting a little bit far away from the CR of this tooth. What you may see at the end, we have some intrusion, but also you have some axial inclination with the roots moving lingually towards the cortical bone of the symphysis on the lingual side. So on the contrary that you may think, this inclination doesn't happen with the center rotation located on the apex, but rather somewhere close to the CR. So we have this type of a movement. So what happened is, and this patient that came to us, this was a treatment that started with another colleague that was leveling and aligning the reverse and trying to open up the bite using a straight wire, a reverse curve of the spit. But probably at the beginning of the treatment, this incisor was a little bit flaring. So that distance, let's go back here a little bit. So this distance, the distance of the force from the CR is a little bit bigger. And according to this distance, your moment will be also bigger. So we know that the moment is just multiply the force by the distance. When you have some incisors, is a lot of a true flare in the beginning. So it's better not started with just want to use a different method to level and align the reverse curve to correct the curve of the spit. Okay, as you can see on the lingual side, you can touch it, you can feel the roots over here due to this axial inclination. So he didn't make anything different from this, just a reverse curve of the spit. And you can see the amount of the root resorption that he got here with this movement, because he threw the abscess of the roots against the cortical bone. Interesting enough, we didn't have a dehiscence, okay, but you can see the great amount of root resorption. So the orientation of this tooth is almost 90 degrees with the alveolar bone. So you can imagine if you continuously insist in using just a single force here, you're just making your case even worse. Okay. So another aspect that I like to call your attention, when you have a great difference between the height of the center incisors, the lateral incisors, I'm sorry, and the cuspid, that give you a geometry that we call a high geometries. Again, for those that are familiar with this high geometry, we have a extrusive force that is somehow something that you wanted acting on the cuspid. And we have an intrusive force acting on the incisors that also is something that you wanted. But also we have this moment acting on the cuspid that has a tendency to move these roots forward against the cortical bone. And we know that the cuspid is right there on the corner of the arch. So at the first stage, we can see some bulgy roots on the lower arch by using this method here. Of course, after you finishing leveling and aligning, these roots will come back again, but it doesn't make any sense. You move the roots forward and back again and making a lot of a round trip movement if you cannot do something different. So just pay attention to it. This is very important that you have in this idea. So for example, this is a clinical situation that you may want to switch to a different modality of treatment to avoid this side effect. So you have a very high degree between the cuspid and the incisors, okay? So what we did here, just using a bursal intrusion arch, so intrude this segment here, as you can see here. And after this, we can just switch it to a straight wire without any problem. Okay, so you can see how nice was the gingiva, not proclination of the incisors, and we also avoid any round trip movement of the roots of the cuspid. Okay, when I was back in my residency, during our analysis, mechanical analysis, treatment plan and mechanical analysis, we used to consider the curve of speed, and according to the amount of the curve of speed, used to make some calculations to add there some millimeters to calculate the total of the space that needed to level and align in the lower arch. And this because we had in mind that the lower teeth assume a position. If you think in this way, you're assuming that the lower teeth, they have an orientation with the roots follow in spokes of a wheel. And this is not really true, okay? So if there is no mesial inclination of posterior teeth or crowning, leveling of the curve of the speed do not require any additional space according to Burston. Why? Because all movement that you needed to do to leveling this curve of the speed is a vertical movement. Okay, just extrusion on this section, on the posterior section, and intrusion of an anterior section. So we used to use like a piece of a brass wire or even a dental floss and put on top of the occlusal surface of the occlusal surface of the lower arch. And after this, we just stretch them. And the differences between, of course, when it's curved, it requires less space compared to the straight when we straight them up, okay? And we usually used to add these differences on our calculations to see, okay, you need 1 more or 2 millimeters according to the amount of a deep bite that we have. But pay attention to this detail. If there is no mesial inclination or grounding, there is no additional space is required to level and align it. Okay, So now we're going to say, presented to you the continuous intrusion arch. That is the bursting intrusion arch. We call it continuous because this active component is just one piece. Okay, so we have an invariance that you're going to see later on. That is the 3 pieces intrusion arch. So this we call it continuous intrusion arch. For this, we have the stabilizer components. That is the lingual arch that comes over here. We have 2 posterior segments. So it's 2 pieces of wire, very stiff wire that is bended totally passive. So you can just use like a 1925 stainless steel wire, do it passively. And to improve the system, you can fill the slot with some resins like Trigel or any other kind of a resin to make it very, very precise. We have the anterior segment here. So this can be any type of wire, even a night-eye wire. If you have some crowding here on this segment, you can solve the crowding at the same time you are intruding them. Okay, this is a great possibility that you have it. And the active component is the intrusion arch itself. Here we go. We have this step bend here that has the goal to avoid any contact with the posterior segment on the brackets of the cuspid and premolars. In those cases that you don't have the cuspid yet or has no any brackets on these teeth, you don't really need to do this bend. I mean, this bend is there just to avoid any contact with the posterior part. Okay, you can use like just a straight wire here with just one V bend there to activate it. It do the same work. Okay, what really matters to us is the amount of force that you're going to measure on the anterior region using a dynamometer here. Okay, so this is what really important to us. So this, when you're going to use this continuous intrusion arch, when you want to apply a force, when you decide the point of force application, you could use this the central here, the midline, or maybe here between the center and lateral incisor that you're going to see if you take a look from occlusal, that is going to be a little bit backwards compared to the midline point. Okay, so when you are going to start your intrusion and you see that your incisors has a very nice or a good axial inclination or a little bit steeper, okay, so you can start using this continuous intrusion arch. But if, just in case, so this is the wire that you may want to use it for, as I already mentioned, for intrusion arch of TMA 17 by 25. For the passive segment, you're going to use 19 by 25, but you may want to do it the 21, 25, but 21, it's very hard to work and make it totally passive. I prefer to use the 19 and fill it up the slots with some resin, as I mentioned. And the lingual arch could be with 36 or 32 stainless steel wire. And this is the variance that we have. As I said, if you need to apply your force more backwards, then we have to switch to the 3 pieces intrusion arch. So the continuous arch allows you to apply a force here or here, but not further than this. And when, for example, we have some incisors that at the beginning of treatment is already a little bit flare with a lot of a buccal inclination, so it's better to move the point of force application a little bit backwards according to our calculation. You have the conditions to do it. You're not going to get into those calculations today. You don't have time to do it today, but you maybe do it in the future. So, but in some, I'm going to give you some, at least some ideas what to do it. So in this case, we have a possibility to apply in many different points backwards. Okay, so the components is almost the same. We have the stabilizer component, we have the TPA, and the 2 posterior segments on both sides to increase your anchorage, okay? Then we have 2 cantilevers that will provide the intrusive force. And just remember that if you decide to intrude these 4 incisors using, for example, for instance, 40 grams of force, so just remember that you have to put 20 grams on this side and 20 grams on this side here. So to bring it up evenly, to keep the orientation, okay? So if you have to sum of them, the 2 forces to give you 40, right? So here, why we do not insert the wire into the bracket, as we see, for example, who does rickets techniques, for example, work with rickets, they used to insert it here, but we don't do it because first, to avoid any second order side effect when we activate it and bring it down to insert it, has a tendency to form a curvature here, that this curvature will move the roots one towards another, and this could be detrimental in some cases, but this is not the main reason that we do not insert the arch into the slot, because the third order side effect will be more important to us. Why? Because the orientation of the bracket is not always coincident with the orientation of the intrusion arch. So for example, if you have to apply a torsion, a clockwise torsion inside, into the wire to put it inside the slot, so it will deactivate in an opposite direction, and this moment, counterclockwise moment, will cause some extrusion of the teeth. And this extrusion of the teeth has this tendency to extrusion, will cancel this intrusive force that you're applying, or maybe it could be even bigger. So you don't see any progress. Maybe your case become even worse. On the other hand, if you have to apply a counterclockwise moment to insert this wire into the slot, it deactivates in opposite direction, and this movement will cause some intrusion. Then you think, well, intrusion, it's all I wanted, it's okay. Unfortunately not, because this intrusive force will be summed with this intrusive force provided by the intrusion arch. So at the end, you may have very high forces or more than you should to apply to this group of incisors, okay? And this, this is what we call it a statically, if we insert it, it becomes a statically indeterminate system, okay? So it means, so here we have inserted into the tube. If we insert it into the bracket, they will be interact between them. So the geometry is going to change every time, and this will not be so predictable type of a movement, okay? So that's why we do not insert the wire into the slot. And then finally, we could add here the possibility to leveling and aligning the anterior segment at the same time that you are intruding teeth. This is another possibility that you have. When we say intrusion, we mean we have an apical displacement of the center resistance of the tooth, and not only just an inclination of this tooth. The inclination, the actual inclination of the tooth gives you a false impression of intrusion, but it's not real intrusion. So this is, we can see more when you use a reverse curve of spit, as I have shown to you. And here is, you can get it. Of course, you can get some some translation, but it's more rare. You can get some translation with reverse curve of spit, but it's not so common. But it's much easier to get it using intrusion arch. So this takes a longer time to happen compared to this one. Okay, that's why sometimes your opponent cross the street using just a reverse curve of the spit, it can correct the deep bite much faster than you that are using intrusion arch. And this, you have to consider this possibility that he or she is not really doing an intrusive force. It takes time to happen. So be patient. When you apply an intrusive force, do not use very high forces, low forces, and put your hand in the pocket and wait until it happens. It takes time, okay? So, but we always think about, okay, when we are doing intrusion, what's the possibility for us to cause a root resorption? That's why I brought this article just published now in 2020. This group of colleagues, they do an assessment using a cone beam computer tomography scans, what is much better way to assess apical root resorption better than X-rays only. And they conclude that something that quite logical, that root resorption is a very frequent consequence of tooth movement. We know this, especially in intrusion and torquing. And one of those reasons I can tell you that when you are applying intrusive force, you have to have in mind that you are compressing a very small area of the roots. Okay, so for example, we know that stress is equal to force divided by area. Okay, so if you have a small area, we have a very high, a bigger stress. Okay, so in this case, the area that has been compressed is very short and can be even worse when we have a patient, for example, adult patient that has some bone loss. The amount, we have less amount of obliqual forces that are some obliqual fibers that are fibers that help us to avoid the intrusion movement. So less resistance, less fiber, less resistance. So this force could be even higher. So just pay attention to it. Never use a very high forces, or even a light forces can become heavier if under these conditions, okay? So this is very important that you have to have in mind. Okay. So the force, the intrusive force should be constant and with low magnitude. It means it must have being appropriate qualitatively and quantitative aspect of the force. The qualitative aspect will be the constant force. It means the center of rotation of the movement should be quite constant, and the magnitude, as I said, and a low magnitude. And for this, you may want to use the spring that could deliver a low force deflection rate that allow us to have this force that is more constant and low magnitude. Also, the force system should be related to the center of resistance of the tooth in order to have a better control and avoid any round trip movement that is very detrimental for any kind of movement, especially for intrusion. And the point of force application that you're gonna see a little bit more about it should be an anterior region with one point of contact. And this is why I just already explained it. We did not insert the intrusive arch into the slots because it becomes a statically indeterminate system, according to Burston, and using just one point of contact is a statically determined system. And these allow us to control the forces, to measure the forces and have a good idea of the force that has been delivered, but just knowing that the amount of activation that you gave and the force deflection rate of the wire. And finally, some anchorage consideration. Of course, if you're applying intrusive force here, you're gonna have some extrusive force in somewhere part of the arch. So we should take care of this and provide the appropriate anchorage for this system. So this is just for you have an idea comparing a high stiff wire with a low stiff wire. Let's consider here an intrusive arch made out of a stainless steel like 1925 or 2125, and a TMA that has a low stiffness or a different module of elasticity, TMA 17 by 25, for example. So to activate this arch wire made out of a TMA, for example, you need less force to get the same amount, need more deflection to get the same amount of force compared to the stainless steel one. Say, okay. So during the deactivation, you stay on the optimal zone a longer time you have a more and more range, a larger range of the deactivation in an optimal zone compared to a high stiff wire. So this gives you a more constant force with a lighter force. So if you deactivate, you have if your force deflection rate is about 10 millimeters, for example, it means for each millimeter you get 10 grams of force. Okay, 10 grams of force. So for having 5 millimeters, with 5 millimeters of activation, you get 50 grams of force. Okay. So after 1 month, it do activation 1 millimeter, and this force becomes 40. It's still a good one. Okay, 1 millimeter later, you deactivate 1 millimeter and become 30 grams millimeter. It is still good. So when it comes to suboptimal zone, so then you activate it 3 or 4 millimeters. On the other hand, if you use a high stiff wire, have a very high force deflection rate, for example, you'll be like 40 grams of force. To get 50 grams, you need to activate 1.5 millimeters. And this is not possible. Nobody is so good to activate 1.5 millimeters, but even consider that you are that good enough to do it, you started with a force that will be a little bit higher, 60 grams. And after 1 millimeter, you are already in a suboptimal zone. So you stay in an optimal zone very, very short period of time. So here we have some numbers as reference. This is taken out from the book from Burstons and Choi. And these numbers are considered for patients with under a very nice conditions, periodontal conditions. And we should just consider that this force, this magnitude of the force couldn't be applied for a patient that has some periodontal problems or bone loss. I'd rather use half of this force for intrusion of a center incisors, for example. Okay, but I'm not saying that you cannot use 40 grams for center incisors. Yes, you could, because we know, and the literature is very controversial about the right magnitude. You can use 40 grams and have the same results that I'm using 20 grams or use 60 grams, whatever. But I prefer to stick to it and use something around 20 grams for upper, 10 grams for low incisors, 4 incisors here, 40 grams. On the upper arch and lower arch, something 30 grams is okay, and so forth. Okay, so just consider this as being your limit, the highest force that you may want to use for intrusion under normal conditions. And where should apply the force? And as I said, the point of force application is one important aspect to be considered when you are talking about intrusive force. And I would say that if you have a very nice axial inclination of your tooth, you may want to apply a force that passes through the center of resistance of your incisors. And what you get you have just an intrusion, a translation of this group of incisor or incisor of just one tooth only. On the other hand, if in the beginning of treatment, you're seeing that your incisors are a little bit flare, as I said in the beginning, it's valid for upper arch and lower arch. So do not use this, or try to avoid, I would say, or be very cautious, be aware that the possibility to increase this flaring if you use, for example, the reverse curve of the spit, okay? So the ideal was using a system that allow it to apply a force back here. In this way, you can intrude teeth and also at the same time correct its axial inclination. And this can be done using the 3 pieces intrusion arch, for example. On the other hand, when you have a very steep center incisor, could be upper or lower, any force that has been applied on the middle section or the midline, you'll be okay. Here is more, you can use, for example, the reverse curve of spit works quite nicely in these circumstances. As you see, there is no good appliance or bad appliance. They're just the right appliance to be used at the right time at the right place, okay? Needless to say that we shouldn't start any dental movement, orthodontic dental movement under these conditions. And this is even more critical when you are dealing with intrusion force, okay? This is mandatory. Send your patients out for the periodontist or general practice for cleaning and keep a good supervision during the whole process to avoid any problem, periodontal problem, active periodontal problem, periodontitis or gingivitis during this process. And here we have some considerations about the force system that we may produce with the intrusive arch. Let's say that we want to intrude this segment, this anterior segment, using force of 40 grams of force, the force magnitude. And of course, you're going to apply just a single point of contact, and we do it just tight the anterior part of the intrusive arch to the anterior segment. Okay, so knowing the equilibrium, we know that this force must be in equilibrium with another force that will act on the posterior part of our appliance at the same magnitude, but in opposite direction. And this is not in equilibrium because only these 2 forces will cause a rotation to our patient's mouth. So now we know that adding this moment, our system will be complete in a full equilibrium. So this is the force system that is acting on our appliance. And to know what the forces that will be acting on the patient's teeth, just reverse the orientation of the arrows. With this, we're gonna have an intrusive force acting on the incisors, an extrusive force acting on this molar, and also a tip back moment acting on this molar as well. This moment may be good, maybe not, you decided. Sometimes you have a mild class 2 and just a mesial inclination of the molar. So a distal inclination will correct your class 2, that's okay. If you're not, it's something that you don't want it, you have to do something else, maybe add a segment of a wire connecting the whole posterior segment to cancel this. Of course, you're not cancel this, it's gonna have this tendency to rotate the whole segment as well, but then you will increase the moment of inertia of the whole segment, okay? So this is through extrusive force. When Burston presented this system back in 1970s, we didn't have any possibility of thinking about skeletal anchorage, okay? So if you don't want this extrusive force, or your patient, you are working on a high angle patient and you saw this, we better increase the anchorage to avoid this extrusion. If you're working in a normal angle patient or in a low angle patient, the 40 grams of force, extrusive force, must be canceled or should be canceled by the occlusion, by the forces produced by the occlusion. So it's not really, we shouldn't worry about this. Okay, so this is the magnitude of the force. And here we have, so this is just for you, this cantilever. I wouldn't bend that high because it bothers your patients very much, but just to make easier for you to see. So to see the orientation of the ligature, give you the orientation of the force that you're applying. So this is in a 3 pieces intrusion arch. This is in a variance. This is another way for you apply a force. You can use a cantilever to give you the intrusive force and an elastic to give you the horizontal force. Here, I'd like to call your attention. This horizontal force should be very, very light. Don't stretch this elastic too much or you're gonna ruin your case, okay? So this is very, very light. You can see the links. I have 1, 2, 3, 4, 5 links here. You can see they are not being stretched very much. In fact, I cut in a piece of elastic that at rest, you'll be like 2-3 millimeters away from the hook, no more than this, okay? And the good thing about this system that you can control, for example, you are intruding, but you are seeing a little bit of flaring of the incisors, so just increase this force a little bit, not that much, just a little bit, okay? How much is a little bit? Okay, so if you have starting 3 millimeters, start with 4 millimeters or 5. We know that the elastic has a decay of the force over time. We know this, okay? But even though we have a decay because they suffer in a process that we call relaxation, even though that they suffer in a decay, the force that you're producing here is enough to keep the orientation of the final force that you wanted. Okay, so you can play with. If it's becoming too steep, so you reduce or even take it out, this elastic, and work only with the cantilever, so you can manage according to your needs. This is a little bit more simple because the ligature gives you the orientation of the intrusive force, okay? So in this paper published by some friends from Austria in 1996, they concluded that in adult patients, the segmented arch technique or the bursting intrusion arch can be considered as being superior to a conventional continuous arch wire technique if arch leveling by incisors intrusion is indicated. And why they say in adult patients? I'd say in adult patients because that condition, adult patients, we have those variances of the periodontal support. It's more common that you have a situation that require a system that apply a force that deliver a very low and more constant force. And now let's see some clinical case before we almost 1 hour of presentation. So I know that after seeing many theory, we are just want to see some clinical cases. And let's start with this young boy here. So as you can see on the spatial analysis, I can see that he has quite nice smile, line of smile. I would rather work on the lower arch to correct this deep bite. And this, what we did it, just start, we bonded on the upper arch, okay? And point bond the anterior segment. But we didn't have a plane of space to bond the bracket here, so some colleagues may want to put some turbo bites to raise the bite, some resins on top of the. So after correcting the deep bite, you can switch it to a continuous arch wire without any problem and follow your normal mechanics that we do. But as you can see, wait a minute. Okay. So you can see here, we intrude the incisors, but we do not flare too much, so they still keep in a good axial inclination. So this is what I wanted. So now we just finished our case normally. Okay. So here another case in an adult patient. In this case, we fortunately didn't have anything to worry about the anchorage, because it's anchored in some dental implants on posterior, so do not have any side effects on the posterior region. So only intrusion on the anterior, and the orientation, the force, the line of action of the force is given by the ligature, as I presented to you, using a 3 arch on the upper arch, but also some continuous, because I didn't want to intrude it that much. It's a patient that is an adult patient, and I don't want to hide too much the upper incisor, so I work on both arcs. Okay, so in the lower arch, we use a continuous arch, and the upper, we had the 3 pieces intrusion arch that give me a forces, has an intrusive component and a distal component to help to close the space as well. So at the end, we got quite nice results that you can compare here. According to Nanda, we have almost 50% of our overlap, so it could be considered severe deep bite. And here we have a normal deep bite between 5 to 25% of the overlap of the upper over the lower incisors. As you can see, any other aspect has been corrected. Okay, so here, just to say that I usually do an overcorrection when I'm reducing the deep bite. So here we are having almost 0 of overlap, because after removing the system, you always have 1 or 2 millimeters of relapse. And normally we do the intrusion of the incisor separately of the cuspid, because if you include the cuspid here, it attacks our anchorage. So do the intrusion of the incisors. Then what we may want to do, put in a passive wire here with some bypass on the cuspid, touching on the linguals, on the buccal surface of the cuspid, so when the intrusive force wouldn't flare the cuspid during the intrusion. The same thing here, you can see after intrude the incisors, we start the intrusion of the cuspid, and separately you can see the difference that we have in the height of the crown. And here after finishing, we have a quite nice situation. Just do it separately to keep your anchorage in a low magnitude of force. And here is another capability of the intrusion arch, in a quite easy case, but as you can see in this patient, she has a cant of the occlusal plane, midline deviation, and deep bite of these 3 incisors here. So what we did, we applied a force off center here, as you can see, the force has been applied here to give me an intrusion and also some moment. Pay attention that we do not include this incisor. This incisor is in a good condition. It doesn't make any sense. We extruded this and intruded again, making a round trip movement. Keep it out of your systems for a while. So after leveling alignment, then finally, you can finishing with a straight wire. In this, just 2 wires, you finish the case quite nicely, correcting 3 problems at the same time: the midline deviation, the occlusal cant, and the deep bite. Another possibility is using the intrusion arch associated with the TPA activity second order, that you give a tip back moment on this side that you'll be boost with the tip back moment of the intrusion arch, help you to correct the sagittal position of this posterior teeth here, correcting the class 2, as you can see here. But on the opposite side, this tendency of a mesial movement produced by the TPA will be canceled by the tip back bend given by the intrusion arch. So you just keep it, the position, original position on the left side. So you can easily correct it by using the intrusion arch as equipment. So, and finally, the use of a mini screw as a possibility to correct a deep bite. These patients came to us for a retreatment. She has been in treatment for a long time using a class 2 elastic. that gave her and did not correct the class 2, but gave her a change of the occlusal plane. The deep bite is still on, and some